Thank you, everyone. We are ready to reconvene the ACIP meeting. We are going to start next into the session around adult RSV vaccines, and Dr. Camille Cotton, who is the work group chair, will provide an introduction and overview of the afternoon session on RSV vaccine in adults.
Thank you very much, Dr. Lee. It's a pleasure to talk about the adult RSV vaccine. Next slide, please. We have a wonderful work group. You can see the ACIP members, the ex officio members, our terrific CDC lead, Michael Melgar, a variety of consultants and liaisons. And I have to say a huge thanks to everyone because they've been very, very active participants during many calls, long calls, and lots of really good discussion and lots of insights and lessons learned. Next slide, please. And then we have our CDC contributors, also incredibly helpful, the Coronavirus and Other Respiratory Viruses Division, the Immunization Safety Office, and we greatly appreciate their input, and the Immunization Services Division. Again, greatly appreciate everyone's help. Next slide, please. So just to recap, last October, we talked about manufacturer safety and efficacy presentation by GSK regarding the adjuvanted candidate RSV vaccine for older adults, the RSV pre-F1. We had a presentation on manufacturer safety and efficacy presentation by Pfizer regarding bivalent candidate RSV vaccine for older adults, the RSV pre-F, and work group interim considerations regarding novel RSV vaccines for older adults. Next slide, please. Recent work group discussion included cost effectiveness of RSV vaccination among U.S. Older adults, GRADE and EtoR for both GSK adjuvanted RSV pre-F1 and also for Pfizer bivalent RSV pre-F, and then a discussion of CDC vaccine safety surveillance systems. Next slide, please. In our recent work group discussions, we discussed possible policy recommendations for RSV vaccines of U.S. older adults, including should RSV vaccines be recommended for U.S. adults aged greater than 65, or should they be recommended for U.S. adults aged greater than 60? And for everyone in the room, I'd just like you to keep an eye on that 60 versus 65. Okay, next slide, please. And before I get to this, I just want to say both GSK and Pfizer have submitted BLAs with the FDA for use of these products in adults age 60 and older. The FDA's target action for regulatory decision is in May of this year. And next week, VRBPAC will be meeting to discuss both of these candidate vaccines. And any policy considerations discussed today are contingent upon FDA approval of these two vaccines. And you can see that we will have several discussions as outlined on this slide. And I think that's it. Next slide, please.
Thank you, Dr. Cotton. Next, we'll move on to Dr. David Hutton from University of Michigan, who will be presenting on the economic analysis of RSV vaccination in older adults.
Good afternoon. I'm happy to share the results of our economic analysis of RSV vaccination in older adults. Next slide. I'd like to acknowledge our research team, which includes collaborators from the University of Michigan and CDC. You can see here. Next slide. We have no conflicts to report. Next slide. Okay, our overall goal was to evaluate the cost effectiveness of RSV vaccination in the U.S. population aged 60 and older. We evaluated vaccination policy for several age groups. We're examining outcomes of resource utilization, cases, costs, deaths, and quality adjusted life years lost from RSV, or with no or without vaccination. With or without vaccination. In the end, we compare the incremental cost effectiveness ratio of vaccination to no vaccination and explore scenario analyses that examine key areas of uncertainty related to these questions. Next slide. We examined two vaccination interventions, GSK and Pfizer vaccines. Each vaccine is individually compared to a no vaccination strategy. The base case assumes that we're looking at RSV vaccination for those aged 65 and older. However, we would look at other potential age groups in the sensitivity analysis. We're looking at vaccination intervention over a time period of 1 year, but we use a lifetime analytic horizon to look at outcomes that might last beyond a year, like years of life lost due to deaths. Next slide. In order to conduct this analysis, we're using a decision tree model. Our decision tree incorporates several parts to it. The top of the diagram shows what happens with no vaccination. Individuals can become infected. Infection can lead to hospitalization, emergency department visits, outpatient visits, or none of the above. Individuals who are hospitalized can potentially die. At the bottom of the tree, you see the outcomes related to vaccination. Vaccination may involve several adverse events, as you can see here, and then individuals can become infected as well. Of course, the RSV outcomes are less likely to happen with vaccination. Using this decision tree, we can calculate numbers of events, costs, quality adjusted life years, and numbers needed to vaccinate for the different outcomes, and cost per quality adjusted life year gained. And again, because this is a decision tree model, it does not take into account any reductions in RSV transmission. And as such, actually, the results are not dependent on vaccine uptake. We also did not take into account infections that are not medically attended. Next slide. One of the key epidemiological parameters is the incidence of RSV. We have to keep in mind that reported incidence might be underreported because of imperfect PCR sensitivity. In our base case, we assume that sensitivity is 95%, and we adjust for that to estimate the true cases of RSV. In a scenario analysis, we examine what results would be if sensitivity is lower, meaning the actual cases of RSV are actually even higher. Next slide. This slide shows our estimates for RSV hospitalization incidence. These estimates come from the CDC RSV net from the season starting in 2015, ending in 2019. You can see rates are slightly lower for the younger age groups and get higher for those over the age of 75. As mentioned earlier, there's considerable uncertainty surrounding these rates. Next slide. This slide shows the incidence estimates of emergency department visits and outpatient visits related to RSV. These rates come from a study by McLaughlin et al. Published in 2022. It's a Pfizer-sponsored meta-analysis. Similar to the hospitalization incidence, the incidence of ED and outpatient RSV visits also increase with age. Next slide. In our model, mortality is linked to hospitalization, so this slide shows our estimates of RSV mortality given that someone is hospitalized. The numbers are also taken from RSVNet, and please note that the probability of dying from hospitalized RSV again increases with age. Next slide. We take seasonality into account. The model incorporates this to take incidence of RSV and timing of RSV vaccination and waning immunity into account. The graph shows the fraction of annual infections occurring in each month. Most of the infections are, again, occurring November through April, and seasonality data comes from nerves. I want to mention that we assume vaccine uptake follows a seasonal pattern similar to influenza vaccination uptake. Okay, now, next slide. We also need to understand efficacy of the RSV vaccines. This slide shows estimates of RSV vaccine efficacy taken from the GSK and Pfizer phase 3 trials. We've chosen to split up efficacy into two components. One component is efficacy against emergency department and hospitalizations, and the other component is efficacy against outpatient visits. We base efficacy on how the trials evaluated RSV lower respiratory tract infections and all acute respiratory infections. We use the efficacy against lower respiratory tract infections to be the efficacy against emergency department and hospitalizations. And we use the efficacy against acute respiratory illness as the efficacy against outpatient visits. As you can see, the efficacy preventing the more severe outcomes is higher than the efficacy preventing outpatient visits. Next slide. So this figure shows our estimate of the GSK vaccine efficacy over the course of a year. We don't have definitive information on long-term efficacy of these vaccines, so we've chosen to model efficacy with an exponential decay in the efficacy over time. We base the efficacy over those first 6 months based on the average efficacy seen in the trials. We can see slightly different efficacy against hospitalization compared to outpatient visits. Next slide. So this next graph shows efficacy estimates for the Pfizer vaccine. Next slide. This one shows the medical costs associated with RSV infections. The table shows estimates of costs for hospitalization at the top, then emergency department visits, and then outpatient visits for RSV. These estimates are taken from a variety of sources that have estimated costs of RSV, and they've all been inflated to $2022 using the GDP deflator. I should mention the hospitalization cost estimates are from a study by Ackerson in 2020, which studies the cost of inpatient hospitalization, but it does not include costs of follow-on care that might occur subsequent to hospitalization, like rehabilitation care. Next slide. Since the vaccines are new, we don't know precisely what the vaccine cost will be. So we start with a nice round $100 as our base case for the price per vaccine dose. This may not be the exact number that payers will pay for the vaccines in the end. So we used a range of $50 to $200 in sensitivity analysis. And we also included $16.96 worth of vaccine administration costs. We also include productivity costs for an individual's time to go get the vaccine. Next slide. We included health-related quality of life losses from RSV, both for outpatient and emergency department visits and from hospitalization for RSV. These estimates of quality-adjusted life years lost come from a study which surveyed people about quality of life lost from medically attended RSV infections. Next slide. I'm not going to show you all of our inputs, but I wanted to mention we also included additional inputs related to RSV illness, such as productivity costs for individuals when they're sick with RSV. We also include productivity costs associated with vaccination, and we include vaccine adverse events and the quality of life, medical, and productivity costs associated with those adverse events. Next slide. We conducted several analyses of uncertainty. We conducted one-way and two-way sensitivity analyses. We also looked at several different potential age-based recommendations for RSV vaccination, looking at vaccinating people. Our base case was age 65 and above, but we also looked at 60 and above, 70 and above, and 75 and above. As I mentioned earlier, we examined a variety of vaccine costs from $50 to $200, and we also do some scenario analyses examining higher RSV incidence. Next slide. Our results start with a base case where we look at a hypothetical cohort of 100,000 individuals. We assume 20% of them would get vaccinated based off the assumption that RSV vaccine uptake would be slightly lower than influenza vaccination uptake. Our base case assumes vaccination of individuals 65 and older with a $100 vaccine cost over a one-year time horizon. Okay, next slide. Here are some resulting health outcomes. This graph shows the number of events that would occur over one RSV season. The black bars are with no vaccination, the red bars are for the GSK vaccine, and the blue bars are for the Pfizer vaccine. You can see vaccination with GSK or Pfizer vaccines would lead to reductions in outpatient visits, emergency department visits, hospitalizations, ICU stays, deaths, inpatient days, and ICU days. These might look like small reductions, but recall here that we have 100,000 people, but only 20,000 of them, or 20%, are assumed to be getting the vaccines in this analysis. Next slide. This slide shows the number needed to vaccinate to avert one of these events for the GSK vaccine. Each different colored bar represents a different age-based vaccination strategy. For example, we would need to vaccinate 84 people aged 65 and older to avert one outpatient visit. But to avert one death, we might need to vaccinate 21,000 people aged 65 and older. You can see the numbers needed to vaccinate are typically lower if we're vaccinating older age groups. And on the next slide, we can see the same results, but for Pfizer. You'll notice that the numbers look very similar. Let's look at the next slide. This graph shows the cost per outcome averted in thousands of dollars. For example, you'd be spending about $8,000 to $9,000 to avert an outpatient visit and be spending about $2 million to avert a death. Next slide. This table shows the overall cost-effectiveness summary measures for the GSK vaccine. We anticipate the GSK vaccine would increase costs by $1.84 million and reduce quality-adjusted life years lost from RSV by 11, leading to an incremental cost-effectiveness ratio of $180,720 per quality-adjusted life year gained. On the next slide, we can see the results for the Pfizer vaccine. We anticipate the Pfizer vaccine would increase costs by $1.92 million and reduce the quality-adjusted life years lost from RSV by 11, leading to an incremental cost-effectiveness ratio of $189,407 per quality-adjusted life year gained. Now I'd like to show our sensitivity analyses on the next slide. So we'll first see tornado diagrams where we vary each parameter one at a time and see how they influence cost-effectiveness of vaccination. Then we'll examine how age and vaccine cost affect cost-effectiveness. And finally, we'll examine a scenario analysis with higher RSV incidence. So this next graph shows how the top 10 most influential parameter assumptions affect cost-effectiveness of the GSK vaccine. On the left side, you can see the individual parameter names, and the bars in the middle show how the parameters affect cost-effectiveness. Recall that the base case incremental cost-effectiveness ratio was about $180,000 per quality-adjusted life year gained. The light blue portion of the bar represents how the incremental cost-effectiveness ratio would change if the parameter were lower, and the dark blue portion of the bar represents how the incremental cost-effectiveness ratio would change if the parameter were higher. If you look at the top bar, and see how the vaccine cost might change the results. So if the vaccine costs were lower at $50 per dose, the incremental cost effectiveness ratio would drop to $83,000 or so per quality. If the vaccine costs were higher at $200 per dose, then the incremental cost effectiveness ratio would increase to about $375,000 per quality. I'd like to point out the red dot in this figure represents the incremental cost effectiveness ratio if the vaccine were priced at $150, which appears to be a likely cost for it. For many other parameters, if the value is higher, the incremental cost effectiveness ratio would drop. For example, if the incidence of RSV hospitalization were much higher, then the incremental cost effectiveness ratio would drop to about $32,000 per quality adjusted life year. The most important parameters are those related to vaccine costs, incidence, vaccine effectiveness, and the costs of RSV. Now let's look at the next slide. The next slide shows the same Venn diagram, but for the Pfizer vaccine. The top parameter here is the vaccine effectiveness at preventing lower respiratory tract disease. It's a very wide bar because the Pfizer vaccine effectiveness had such a wide confidence interval on it. Here we can also see that vaccine cost is an important parameter. The red dot here shows if the Pfizer vaccine had a cost of $200 per dose, and the incremental cost effectiveness ratio would be about $384,000 per quality. If the vaccine costs were only $50 per dose, however, the incremental cost effectiveness ratio would drop to about $92,000 per quality adjusted life year gain. On this graph, we see similar parameters being important to the incremental cost effectiveness ratio. Vaccine effectiveness, vaccine cost, and incidence are important parameters. So the next slide shows how vaccine cost and changing the population that's vaccinated would affect the cost effectiveness of the GSK vaccine. Each colored line represents a different age group vaccinated. The top red line represents vaccinating individuals aged 60 and above. The blue line at the bottom represents vaccinating individuals aged 75 and above. And the yellow line in the middle is our base case analysis of vaccinating individuals 65 and above. We can see vaccinating older age groups is more cost effective, and a lower cost vaccine would be more cost effective. The blue dot represents our base case assumption of a $100 vaccine, and the red dot represents a potential $150 vaccine. The next graph shows the same information, but for Pfizer vaccine. The blue dot also represents the $100 vaccine cost, but the red dot here represents a $200 cost per dose of the vaccine. Next slide. So the next few slides will show scenario analyses with higher incidence. Recall that there's uncertainty about what the precise incidence of RSV is, particularly given some uncertainty in how precise our tests are at detecting RSV. In our base case, we assume 95% sensitivity, which suggests we're not missing too many cases of RSV. However, if actual sensitivity were lower, as suggested by a 2016 study by Zhang et al. And a 2022 study by McLaughlin et al., we might be missing more cases of RSV, meaning actual RSV cases might be about 40 to 50% higher than reported. So on our next slide, we'll show that incidence is indeed higher. This graph shows what the incremental cost effectiveness ratio would look like for the GSK vaccine. This figure is similar to the other vaccine cost analysis graph, but it only shows the line for age 65 and above being vaccinated. The solid line is our original base case, but the dotted line at lower is with the higher RSV incidence. So if the vaccine were to cost $100 per dose, for example, the incremental cost effectiveness ratio would drop in half or so to be about $91,000 per quality adjusted life year gained. On the next slide, we see the same results, but for the Pfizer vaccine. With higher incidence and a $100 cost per vaccine dose, the incremental cost effectiveness ratio would drop to about $104,000 per quality adjusted life year gained. Let's go to the next slide. I'd like to highlight some limitations of our analysis. The model structure does not contain varying risk groups besides age. This analysis is really for a general older age population. The model does not include dynamic transmission, so the vaccine does not reduce population transmission of RSV. And as I mentioned earlier, there are no medical costs after hospitalization like rehabilitation. Additionally, models like this are a function of the underlying parameter assumptions, and we have many uncertain inputs. We're uncertain about what the actual vaccine costs will be for payers. We don't have perfect information about RSV incidence, and we lack data on long-term efficacy. Next slide. So in summary, the cost effectiveness of RSV vaccination depends on many factors. The vaccine cost could cause the incremental cost effectiveness ratio to vary substantially between about $80,000 and $385,000 per quality adjusted life year gained. Vaccine efficacy could also cause the incremental cost effectiveness ratio to vary between $150,000 and $575,000 per quality adjusted life year gained. The ages recommended for vaccination could also cause the incremental cost effectiveness ratio to vary substantially between about $100,000 and $230,000 per quality adjusted life year gained. And finally, the incidence of hospitalization could cause the incremental cost effectiveness ratio to vary a lot between maybe $30,000 and $250,000 per quality adjusted life year gained. So under certain conditions, RSV vaccination may be cost effective, but under other conditions, it might look like an expensive intervention. And with that, I'd like to stop and answer any questions you might have.
Thank you very much for that presentation. It's now open for questions. Dr. Paling.
Thank you very much for this presentation. I'm trying to understand, when you look at all the various scenarios, which are the scenarios in which such a vaccine would be cost neutral or cost saving? Thank you.
That's a good question. Actually, we didn't find many scenarios where it would be cost saving. I think you'd have to find a scenario where several things were happening at the same time. So I think if you had, I mean, even if you had higher incidence or you had and a much lower vaccine cost, that could cause things to be close to cost saving. We did look at a scenario with a 3-year time horizon, and assuming that the vaccine efficacy decays at an exponential rate, it is possible with higher incidence and over a longer time period that potentially it could be cost saving.
I don't see any other hands raised. One last call. Dr. Daly.
Just a quick question. Can anybody frame the typical qualities for routinely recommended vaccines in prior decisions? I mean, in terms of, yeah, just that. Thank you.
Dr. Hutton, I don't, just for context, just and clarification maybe to Dr. Daly. So are you saying, sort of thinking through what have been some of the cost effectiveness thresholds in the past, or are you talking about qualities specifically?
Well, cost effectiveness thresholds in the past, yeah.
Dr. Hutton, do you want to answer, or I'll actually call on either you or Dr. Ortega-Sanchez?
I mean, I guess I'll start and just say that there isn't necessarily a clear threshold here in the United States. I mean, anything less than $50,000 per quality is typically seen as highly cost effective here in the U.S. But a lot of people would argue you should be willing to spend $100, $150, or maybe even more thousands of dollars per quality adjusted life year gained. There isn't necessarily a right answer here in the U.S., unlike in the UK, where, for example, where they have very specific thresholds. Maybe I'll let Dr. Sanchez Ortega.
Go ahead, Dr. Ortega Sanchez.
Yeah, just to briefly say that there has been all the time discussions about what is a good threshold and if they will be using the threshold or not. For many years, there have been use of $50,000 per quality. Then that proved to be not substantiated either by theoretical principles or theoretical concepts or data. Then it was raised to $100,000 per quality. That's also something that was only inflated by, it was corrected by inflation. So to say that there is no specific threshold, that's, I think, the basic statement. There have been other thresholds that have been suggested by, for example, international organizations like the WHO, which will be three times the GDP per capita. In the case of the United States, it would be approximately $180,000 per quality. Yeah, because we are talking about $60,000 per GDP per capita. So, but that is only a suggestion, and CDC usually doesn't adopt that kind of thresholds. Thank you.
Thank you. Thank you. And with that, we'll move on to your presentation, Dr. Ortega-Sanchez. I'm finally figuring out the pattern here. Thank you for presenting, and the title of your talk.
Thank you. Good afternoon. This is the story of 2 candidate vaccines and 3 models: the economics of vaccinating older adults and the United States against RSV. My name is, again, Ismael Ortega Sanchez. I'm the senior economist of the NCIRD. And this afternoon, I will attempt to compare and summarize key elements and findings of these 3 economic studies. At the risk of ruining your digestion, I hope too much economics is not too much for you. The 3 of the models were discussed in extensus in the adult RSV ACIP working groups. And in this slide, what we can see is that 2 of these studies have been conducted by manufacturers of candidate vaccines. The first study was conducted by GlaxoSmithKline, and its GlaxoSmithKline manufactures the adjuvant RSV Pre-F3 vaccine. The second, the Pfizer model, is Pfizer manufactures the bivalent RSV Pref vaccine. And the third is an analysis that you have just seen by Dr. Amy Houghton in collaboration with the University of Michigan co-authors and CDC collaborators. I will refer to this model as the CDC model. For full disclosure, I have been part of this team conducting the CDC model, and there is no conflict of interest of all the authors. Next slide, please. The starting point of the 3 economic models is the policy question regarding potential recommendations for the use of RSV vaccine in older adults populations. So therefore, to consider the economic of the policy question is to consider simultaneously the health benefits and cost vaccination, namely it's vaccinated older adults against RSV cost effective. The 3 models use the same comparator to address this question, unvaccinated older adults, and focus on analyzing the cost effectiveness of RSV immunization in this age group. Next slide, please. The policy question also defines key elements in the 3 economic models, namely the modeling approach, the inputs of RSV disease burden, vaccine efficacy and costs, and some influential assumptions that need to be defined carefully because of the policy question in consideration. I will go into some of the details in the following slides. Next, please. In general, the 3 models follow similar designs, namely, they all use a static analytical decision-making approach, relying on probabilistic, or in the case of the CDC model, deterministic sensitivity analysis to manage the various data uncertainties. They model hypothetical cohorts of US adults, 60 and older or 65 and older, in order to align with the policy questions. They use reasonable timeframe analytical horizons and discount rates. They also accounted for loss of income associated with temporary productivity loss and 2 premature RSV-associated deaths. Next slide, please. Again, as was mentioned before, once models were set, they were fed by different types of input data, clinical, epidemiological, economic, quality of life, and the vaccine characteristics, the candidate vaccine characteristics. Across models, the sources, the specific values, and assumptions of these parameters had some overlaps, but there were marked differences, as we will see in the following slides. For your consultation, the reports that were submitted for this, containing the economic analysis of these 2 pharmaceutical companies and the UCIT and CDC model, are available for consultation. In particular, we will focus on the incremental cost per quality safe, and in some cases, we will mention the number needed to vaccinate in order to prevent a health outcome. So, next slide, please. Now, before beginning the examination of the outcomes, I want to correct my previous statement. I said that it was the story of 2 vaccines and 3 models. In reality, the CDC model, as you have seen, is not one model, but 2 models in one, meaning that using the data of vaccine efficacy and safety provided by each manufacturer, the CDC model reports separate health and cost effectiveness outcomes for each vaccine. As shown here, the CDC model reports cost per quality safe estimates for GSK and Pfizer vaccines, differentiated by age at which the vaccination program would begin. Although the ICERs, the cost per quality safe, are slightly higher for Pfizer relative to GSK, they are basically in the same ballpark for each age at which the potential vaccination program will be recommended to start. Next slide, please. However, the manufacturer's models' main outcomes, when compared to those of the CDC model, show significant discrepancies. Even though the CDC model assumes a lower vaccine cost per dose for both vaccines, the resulting costs per quality are much higher than those of the GSK and Pfizer. Specifically, the CDC estimates are about 3 times higher than those of GSK and 4 times higher than those of Pfizer for either the adult 60 and over or 65 and over strategies. Next slide, please. To understand these discrepancies, We try to identify the present and present the source of these differences in this and the following 3 slides. Here, the CDC model provides the one-way sensitivity analysis for each vaccine. And again, just to replicate what Dr. Helen was mentioning, these tornado figures help to identify and rank the most influential input variables from top to bottom. The solid vertical blue lines describe the base case cost per quality value. Each horizontal bar represents an input variable in the model. The size of the horizontal bars and the direction describes the influence of each input when either its higher or lower values are used instead of the base case value. Note that either in the first or the second ranking place is vaccination costs. Also ranked high in the vaccine is the vaccine efficacy, and the epi variables such as the hospitalization rate and initial vaccine efficacy are also close to the top. Next slide, please. In a similar fashion, GSK model reported a tornado figure with the most influential variables. The figures focus on the 10 most influential variables are described here. Among these variables are the RSV IRI incidence, and in the 6th place is the vaccine costs. Next slide, please. Pfizer does also report one-way sensitivity analysis where most influential variables are identified. Now, you may say that this is not a tornado diagram, but in fact it is laying down. Yeah. At the very top is the vaccine efficacy against hospitalization, followed by vaccine price, fatality rate after hospitalization. Note that the vaccine efficacy against outpatient visits is in the 5th place, as well as the medical, followed by the medical cost in 6th place. Next slide, please. Aside from the cost of the vaccine dose, the common influential variables identified during the reports submitted to the ACIP, as well as the other information, we could group this into these 3 categories: RSV hospitalization rate, unitary medical cost of RSV outcomes, and initial vaccine effectiveness and waning over time. Now, these slides have a lot of information, but I will be going in detail in some of these ones in the following slides. Next slide, please. If we look closer within them, we could see marked difference in the rates of hospitalization and outpatient illness, as well as in the unitary medical cost of hospitalization. As shown in this table, the hospitalization rates and medical costs as input data points used in the Pfizer model are on the high end, while those used in the CDC model are on the lower end, with GSK input values somewhere in the middle. The committee should bear in mind that the higher these input values are in the models, the lower the ICERs, or the incremental cost per quality, would be, or what is equivalent, the more cost-effective a potential vaccination program will look like. Next slide, please. Particularly influential is the rate of hospitalization, and it is also the input data with more uncertainty, recognized also by the manufacturing models. In this slide, particularly the GSK model, this shows the inverse relation between the cost per quality and the RSV hospitalization rate. It also shows that their base case, falls somewhere in the middle within the most scenarios, with most scenarios to the left of the higher cost, and some others to the right and lower cost per quality. Now, one might think that each of these scenarios is equally likely, yet it could be observed that the rates to the left of their base case are mostly from the peer-reviewed publications in the last 10 years, while those on the right rely on either secondary sources or are used as inputs in some cost-effective analysis as well. So it could be argued that considering these uncertainties, the quality of data may be higher on the left than on the right, considering the point of comparison, the base case analysis. Next slide, please. Likewise, Pfizer also reported a similar correlation as shown in this figure, correlation between the incidence rate of hospitalization and the cost per quality. However, all the alternative scenarios, most of which are based on similar published sources as those of the GSK figure, are to the left and high on their compared to the base case scenario. An important detail, the data source of the base case scenario in Pfizer model relies on an ongoing, unvetted, and published prospective study with adjusted RSV detection rates. The source is reported as Pfizer data on file. Despite this data, the Pfizer data are not available yet for independent review. Their input value, the 300 per 100,000 population rate of RSV hospitalization, was selected for their base case. Next slide, please. In an analogous way, the CDC model also reported this correlation. And for adults 65 and older, the cost per quality saved for each vaccine reported as the $180 for GSK and $189 for Pfizer, $1,000 per quality save. You can see where they lied. To consider the uncertainty about the rate of hospitalization in the CDC model, the quality of data, the range in the model shown here by the dotted vertical lines rely on those reported in the peer review sources. Now, on the next slide, please. Now, when we focus on the initial or early peak of vaccine efficacy inputs, the three models show similar, if not equal, input values for these variables and RSV-associated disease outcomes. And but this will help us to understand where they start and what comes next, which is the duration of protection. Next slide, please. Although it is important how well the vaccine effectiveness starts at the beginning of the RSV season, it is much more significant how it performs during the whole season. The three models relies on available duration of protection data from both vaccines trials that cover the first 6 to 7 months. However, after this initial period, the residual protection is basically an assumption. Both the GSK and CDC model assume no residual protection after month 12, although the GSK uses an initial peak and a linear decay, while the CDC uses an exponential decay to fit the initial vaccine effectiveness and the presumptive residual after 6 to 7 months to drop later to zero protection at the 12th. Unlike the GSK and the CDC models, after the initial period, Pfizer model assumes a linear decay reaching zero vaccine effectiveness at 24 months after vaccination. Now, before you may think that since the second year in Pfizer efficacy may still be low and have a very low impact on the cost per quality, I think you should consider that though, because in the next slide, we will be able to see clearly how this impacts. Thank you. Next slide, please. This slide shows the figure reported by Pfizer dealing with different scenarios for duration of protection and data sources for RSV-associated disease outcomes. By focusing only on duration of protection, we could see that if the duration will wane to 0% at 12 months, the cost per quality will increase from $44,000 per quality to more than $106,000 per quality if we follow the same shades of blues from right to left, outlined by the dotted oval, red oval. Moreover, with different data sources for the RSV-associated disease outcome rates, namely the scenario named CDC times 1.4, which is an inflated, which is a data from CDC inflated 1.4, yeah, you can see that in scenario number 1, where the duration efficacy wanes up down to 0 at 12 months, the cost per quality that Pfizer will calculate in their own model goes up to $171,000 per quality, which is very close to what the CDC model was calculating, yeah, although there need to be some other caveats to consider into that. Next slide, please. In this slide, and using only the CDC model, and this is just only a summary of the many results that have been considered in the scenario analysis by Dr. Luton, we can see some of the scenarios summarized here by each one of the vaccines and reported for cost per quality. As you can see, if the vaccine costs $200 per dose, with only 1 year time frame, the cost per quality for GSK will be almost 100% higher than the base case scenario, and basically the same happens with Pfizer in the Pfizer scenario. Compared to the base case, the cost per quality will be 15% higher if vaccinated adults start at age 60 instead of 65. If we use the lower bound of medical costs for hospitalization, the increase will be only 10% higher. On the other hand, RSV incidence adjusted outward for increased diagnostic yield will yield from testing in addition to RT-PCR on a respiratory specimen will decrease the cost per quality to approximately 50% of the value that is considered the base case scenario. Similarly, when reducing the vaccine price per dose to $50 per dose, the cost per quality will be reduced considerably to less than 50% compared to the base case scenario. Next slide, please. There are a number of limitations, and some of them were outlined during the last slides. Yeah, I want to focus on what factors might not have been considered in the models that may have underestimated the cost effectiveness of vaccination or overestimate the ICERs. Among them are these two. None of the two models include RSV-related medical costs incurred after discharge from RSV-associated hospitalization or emergency department visits, like, for example, stay long-term care or rehabilitation facility, costs associated with assisted living at home, and productivity losses incurred by caregivers whose support is needed for post-discharge. Also, none of the three models assume indirect effects. There were no indirect effects included in the models, so no protection against RSV transmission. I want to also acknowledge that vaccine efficacy beyond clinical trials follow-up time, the 6 and 7 months, is unknown, and therefore the models are very sensitive to the assumption of duration of protection, as you can see here. Next slide, please. In conclusion, difference in key inputs among GSK, Pfizer, and CDC models explain difference in results. And these 4 variables are the ones that are found more influential, with the Pfizer model using more less conservative estimates and the CDC model using more conservative estimates, if you want to consider it from that point of view. Assumptions and selection of input data were crucial in difference in ICERs as well, specifically adjustments approach of incidence rates of hospitalization, ER, and outpatient, and the selection of medical cost sources and data extraction approach. Yet in general, in the base case of the 3 models, we can say that vaccination will significantly reduce RSV disease burden in older adults. But the big clinical trials data and the assumptions support the impact of disease reduction. However, the economic value of RSV vaccine appears to be costly and could be cost-effective if some factors are taken into consideration, like RSV incidence, related healthcare costs, initial vaccine efficacy, and duration combined with reasonable vaccine price will in fact determine the cost-effectiveness value of RSV vaccination. Next slide. To finish this summary, let me please acknowledge my collaborators who helped me to put together this presentation, and also the members of the Adult RSV Working Group and the ECON team at ISD NCIRD. Thank you. I'm open for your questions now.
Thank you so much for that presentation. It's now open for questions. I mean, just from a big picture perspective, I will say I wanted to echo Dr. Daly's earlier comments that like this session and the prior session just reflect how much innovation there's going on in this space, which is pretty impressive and sorely needed. It's also challenging because it's clearly less cost-effective than many of our other interventions in the past. So I think we're all just sort of struggling with that. But I think the clear and transparent way that this was presented actually at least gives us the understanding that we need walking into this decision. So thank you for all your work on that. Dr. Zahn, I see your hand is raised.
Yeah, great. Yeah, thank you, Dr. Lee. Great presentation. I guess one just general question I have is, it seems like this model varies a great deal depending on the RSV hospitalization rate, and those rates seem to vary depending on the study. The CDC think that there's a way forward to eventually get a better sense of that, and is part of the issue simply that there is a large variation from year to year in the hospitalization rates that occur in the country.
Hi, this is Michael Melgar. I'm the CDC work group lead for RSV in adults. I think that's a great question. And I do want to acknowledge that surveillance for RSV disease has not been as robust, for example, as surveillance for influenza over the last 10 years or 20 years. And as we've seen from actually all three of the models that were presented by Dr. Ortega-Sanchez, that the incidence of RSV hospitalization happens to be one of the most influential parameters that determines how cost-effective it would be to vaccinate against RSV in this age group. And as Dr. Ortega-Sanchez showed, even within CDC-derived estimates of RSV epidemiology, there is a tremendous amount of uncertainty in the per-population incidence of RSV hospitalization. And I think you can see that reflected in the charts that were showing the sensitivity of the incremental cost effectiveness ratio by the model input of how many RSV hospitalizations are actually out there year to year. So, you know, CDC continues to work on its surveillance systems to update these estimates. The uncertainty interval continues to be very wide, and I want to acknowledge that. Thank you.
Thank you. Dr. Paling?
I wanted to build on that same question. If you would, I think it's slide 8, where you're comparing the different model comparisons. Oh. No, I'm looking at the one where you've got the CDC and GSK and CDC and Pfizer. Yes, that's the slide. Okay, so this seems to be telling me that there's a lot of assumptions and a lot of questions, and how you look through this matters. One of the other sensitivities that I noticed was that the older the age, the more effectiveness. Would you remind me what percentage of the population was 75 and older in the studies that we saw before? And how much are we inferring? Thank you.
Thanks, Dr. Paling. Do you mean within each model, what percentage of the general population was 75 and older?
No, I'm trying to remember from the studies that we've been seeing from GSK and Pfizer, what percentage of the population do we have data on?
I don't know those numbers off the top of my head. So what proportion of the study population in the phase 3 trials was 70 and older, 75 and older, 80 and older. I will present, though, during the evidence to recommendations framework presentation. One of the key factors and considerations that the work group talked about was the fact that 80-year-olds and older were substantially underrepresented in the clinical trials.
Dr. Talbot. She put down her hand. Okay.
I didn't mean to put it up.
Dr. Ortega-Sanchez, one quick question, which is, and I was inferring this from the way you had presented the information, but the time horizon for the 3 models, it sounds like Pfizer uses a 2-year time horizon and the CDC and GSK models are a 1-year time horizon?
Yes, that's correct. And as I said here, this is usually the time horizon is I think there is a confusion between what is the concept of time horizon and time frame. Time frame is the intervention, and therefore the intervention including how long it lasts the vaccine efficacy. Yeah. In that case, the time frame that was used for CDC and GSK models is 12 months, because mainly we have data for vaccine efficacy duration for 6 to 7 months, and after that, everything is an assumption. Yeah. Whereas for Pfizer, they use a 24-month, although they also have only 6 to 7 months duration data, and then that after that is an assumption, and they assume a linear decay to 24 months, reaching 0% of efficacy protection.
Thank you so much. That's really helpful.
Just to clarify that the selection of time frame is irrelevant if you are assuming seroprotection after 12 months.
Thank you.
Yeah.
I don't see other hands raised in the room, so thank you very much to our two presenters on cost-effectiveness analysis, Dr. Hutton and Ortega-Sanchez. We will move on to Dr. Michael Melgar, who will start us in on the ETR and grade for RSV vaccines for adults.
Good afternoon, and thank you to ACIP for your time and consideration of these products. So I'm Michael Melgar. I'm the CDC workgroup lead for RSV vaccines in adults. Today, I'll be presenting evidence to recommendations frameworks for 2 candidate RSV vaccines for use in older adults, manufactured by GSK and Pfizer. We'll discuss 2 policy questions for each vaccine. Should vaccination with GSK RSV pre-F3 vaccine, which includes an adjuvant, rather than no vaccine, be recommended for persons 65 years of age and older, or 60 years of age and older? Should vaccination with Pfizer bivalent RSV pre-F vaccine, rather than no vaccine, be recommended for persons 65 years of age and older, or 60 years and older? These are sort of duplicative policy questions with a lot of overlap. For simplicity, I'll present the evidence to recommendations framework from the perspective of a vaccination policy for adults 65 and older. At the end of the presentation, I'll summarize the workgroup thoughts regarding the pros and cons of selecting a 60 versus a 65-year threshold. This is the evidence to recommendations framework used by ACIP to make policy decisions. It includes 7 domains with questions in each that I'll cover as I describe the workgroup interpretations. Some components will be the same for both manufacturers and will only be presented once, while others will be manufacturer-specific. The public health problem will go over RSV in older adults broadly. Values, acceptability, and equity will focus on RSV vaccines broadly. And manufacturer-specific data will be presented for benefits and harms, feasibility, and resource use. The first domain we'll focus on is the public health problem. While RSV is recognized by pediatricians, there is a lower awareness of RSV in adults among healthcare providers and the public. Even though it's not often recognized as a cause of illness in adults, there's substantial uncertainty in RSV epidemiology, as we just talked about, we know that the burden of disease in older adults is significant. This pyramid shows burden estimates for adults 65 years and older, dating to before the COVID-19 pandemic. From the bottom up, RSV is estimated to cause approximately 1 million medical encounters, 60 to 160,000 hospitalizations, and 6 to 10,000 deaths per year. The next few slides show data from CDC's RSVNet. RSVNet provides active population-based surveillance of laboratory-confirmed RSV-associated hospitalizations at sites in 12 US states. The combined catchment area is estimated to account for almost 9% of the US population. Here are seasonal rates of RSV-associated hospitalizations among adults stratified by age. You can see that hospitalization rates were substantially higher among adults 70 to 79 and 80 years or older compared with younger age groups. Focusing on the potential age thresholds of interest, adults 60 to 64 and 65 to 69 experienced intermediate rates of hospitalization. Among adults hospitalized with RSV, a large proportion are severely ill, as measured by the proportion admitted to ICU and the proportion who died. In these RSVnet data from 3 seasons, we see that mortality was highest in those 65 years and older at 5%. However, note that the proportion admitted to ICU was over 20% even in younger patients aged 18 to 49 and those 50 to 64. This likely reflects the fact that younger patients hospitalized with RSV have underlying medical conditions that make them more vulnerable to severe outcomes. RSVnet data reflect only patients hospitalized with lab-confirmed RSV, and more severely ill patients are probably more likely to be tested for RSV. So these data may overestimate the proportion with severe illness. Regardless, it's clear that RSV can cause severe disease in hospitalized adults of any age. Turning back to the published literature, there's evidence that adults with certain underlying medical conditions are at higher risk of RSV illness, particularly hospitalization. The list of medical risk factors has not been as well documented as that, for example, for influenza, but adults with immune compromise, especially those with hematopoietic stem cell transplant or solid organ transplant, particularly lung transplant, those with cardiovascular disease, diabetes, COPD, and asthma, have been shown to have higher risk of RSV hospitalization than adults without those conditions. In summary, RSV is a frequent, often unrecognized cause of severe respiratory illness in older adults. A high proportion of adults across the age spectrum who are hospitalized with RSV are admitted to ICU, and death is more common with increasing age. The work group felt that RSV disease was indeed of public health importance among adults aged 65 years and older. Next, I'll talk about benefits and harms of vaccination. We'll approach this section one candidate vaccine at a time, starting with GSK's adjuvanted vaccine. I'll present the grade summary reviewed by the work group, followed by a number needed to vaccinate analysis. Then I'll present the same for the Pfizer bivalent vaccine. First, shown here is the PICO question and the outcomes we'll focus on. Both manufacturers enrolled adults 60 years and older in their large phase 3 trial, and data from all participants in this age group were included in grade. The intervention was either of the 2 vaccines under consideration, the comparison was no RSV vaccine, and the outcomes included RSV lower respiratory tract illness or disease, abbreviated here as LRTI or LRTD, medically attended LRTI or LRTD, hospitalization for RSV respiratory illness, severe RSV respiratory illness requiring supplemental oxygen or other respiratory support, death due to RSV respiratory illness, serious adverse events, inflammatory neuropathy, which includes Guillain-Barré syndrome, and severe reactogenicity. So let's begin with GSK's candidate vaccine. Here are the CDC calculated vaccine efficacy estimates over one RSV season of follow-up for the outcomes that can be considered benefits of vaccination. GSK's pivotal phase 3 trial was the source of data for all outcomes. The efficacy against RSV LRTD, a critical outcome, was 82.5%. However, the work group was concerned about indirectness because adults 80 years and older who are at greatest risk of severe RSV disease were underrepresented in the trial relative to the US population of adults aged 60 and older. Additionally, persons with immune compromise were excluded altogether. The efficacy against medically attended RSV LRTD was 87.5%. The work group was concerned about indirectness for the same reasons. Efficacies against hospitalization, severe RSV respiratory illness, and death were not calculated due to no or few events recorded in the trial. These outcomes were considered important but not critical by the work group. And here are the outcomes that are potential harms of vaccination. In addition to the pivotal phase 3 trial, an early phase dose selection study also reported these outcomes. The pooled relative risk of serious adverse events, a critical outcome, was 1.03. And the work group had no serious concerns in the certainty assessment. The pooled relative risk for severe reactogenicity events was 4.1, with a confidence interval that did not include 1. The work group had no serious concerns in the certainty assessment here either. Finally, the outcome of inflammatory neuropathy was not formally evaluated in grade because there were no events in the included studies. However, one case of Guillain-Barré syndrome was recorded in a recipient of the investigational vaccine in an open label trial without a placebo arm. This trial was not included in GRADE due to a lack of an unvaccinated comparator group. Across all trials, there was a total of 1 case of inflammatory neuropathy among approximately 15,000 investigational vaccine recipients. In summary, the GSK RSV vaccine likely reduces RSV LRTD with moderate evidence. The GSK vaccine also likely reduces medically attended RSV LRTD with moderate evidence. The investigational vaccine results in little to no difference in serious adverse events when all organ classes and types of serious adverse events are considered. And the vaccine increases severe reactogenicity events with high certainty. There was insufficient data to evaluate the outcomes of RSV hospitalization, severe illness requiring respiratory support, death due to RSV respiratory illness, and inflammatory neuropathy. And the overall certainty of evidence was considered moderate. And finally, here are the results of a number needed to vaccinate analysis performed by our colleagues at the University of Michigan as part of the cost effectiveness analysis. 84 adults aged 65 years and older would need to be vaccinated to prevent 1 outpatient visit over a single year. Over 1,000 would need to be vaccinated to prevent 1 hospitalization, and over 21,000 would need to be vaccinated to prevent 1 death due to RSV. You can see that the numbers are larger for adults 60 and older. That's primarily because there is less existing RSV disease in that group at baseline for the vaccine to prevent. Notably, the time horizon matters here. If we were to assume that the vaccine would have non-zero efficacy during a second year, even if it wanes substantially, the number needed to vaccinate could be smaller if the analysis were extended for a second year. When asked how substantial are the desirable anticipated effects of GSK's candidate vaccine among adults 65 years and older, the work group responded that they were moderate or large. And regarding undesirable effects, the work group's majority opinion was that they were minimal or small. However, a minority opinion was that the magnitude of these effects was unknown. These work group members were concerned about the case of Guillain-Barré syndrome in the cross-trial safety dataset, as it's hard to know from a single case if this was a true safety signal or a random event. When asked regarding the balance of desirable and undesirable effects, the work group majority opinion was that the comparison favors the intervention. There was a minority opinion that the balance was unclear in light of the single observed case of inflammatory neuropathy. Now we'll switch gears and discuss the Pfizer investigational vaccine. Here are the CDC calculated vaccine efficacy estimates for the outcomes that could be considered benefits of vaccination. Pfizer's pivotal phase 3 trial was the source of data for all outcomes. The efficacy against RSV LRTI, a critical outcome, was 85.7%. However, as was the case for the other candidate vaccine, the work group was concerned about indirectness because of underrepresentation of adults 80 years and older, and because persons with immune compromise were excluded. The efficacy against medically attended RSV LRTI was 80%. Again, the work group was concerned about indirectness for the same reasons. Counts of RSV-associated hospitalization and severe RSV respiratory illness were not provided by the manufacturer, so efficacy was not calculated. There were no RSV-associated deaths recorded in the trial. Again, these outcomes were considered important, but not critical. Here are the outcomes that are potential harms of vaccination. In addition to the pivotal phase 3 trial, an early phase formulation selection study also reported these outcomes. The pooled relative risk of serious adverse events, a critical outcome, was 1.01, and the work group had no serious concerns in the certainty assessment. The pooled relative risk for severe reactogenicity events was 1.47. The work group had concerns about imprecision because the confidence interval for a measure of absolute risk included the potential for both benefit and harm. 2 events of Guillain-Barré syndrome, or a variant thereof, occurred among recipients of the investigational vaccine, compared with no events among placebo recipients. Due to the small number of events, measures of relative and absolute risk were not calculated. In total, these were the only 2 cases of inflammatory neuropathy that occurred among approximately 26,000 recipients of the investigational vaccine across all clinical trials. In summary, the Pfizer RSV vaccine likely reduces RSV LRTI with moderate evidence. The Pfizer vaccine also likely reduces medically attended RSV LRTI with moderate evidence. The investigational vaccine results in little to no difference in serious adverse events when all organ classes and types of SAEs are considered, and the vaccine likely increases severe reactogenicity events with moderate certainty. There was insufficient data to formally evaluate the outcomes of RSV hospitalization, severe illness requiring respiratory support, death due to RSV respiratory illness, and inflammatory neuropathy. And the overall certainty of evidence was considered moderate. Here's the number needed to vaccinate analysis for Pfizer's vaccine. 95 adults age 65 and older would need to be vaccinated to prevent one outpatient visit over a single year. Almost 1,300 would need to be vaccinated to prevent one hospitalization, and almost 25,000 would need to be vaccinated to prevent one death due to RSV. Again, the numbers are larger for adults 60 and older because there is less baseline RSV disease in that group for the vaccine to prevent. When asked how substantial are the desirable anticipated effects of Pfizer's candidate vaccine among adults 65 years and older, the work group responded that they were moderate or large. And regarding the undesirable effects, the work group's majority opinion was that they were minimal or small. However, again, a minority opinion was that the magnitude of these effects was unknown. These work group members were concerned about the 2 cases of inflammatory neuropathy observed in the main phase 3 trial, as it's hard to know from 2 cases if this is a true safety signal or random events. And when asked regarding the balance of desirable and undesirable effects, the work group majority opinion was that the comparison favors the intervention. There was a minority opinion that the balance was unclear in light of the 2 observed cases of inflammatory neuropathy. Next, we'll discuss the domain of values, in which we'll explore how the target population feels about the potential desirable and undesirable effects of RSV vaccination. I'll be drawing from unpublished results of an online survey developed by CDC in collaboration with the University of Iowa and the RAND Corporation. The survey was designed to assess vaccination intentions for a hypothetical RSV vaccine among US adults 60 and older. The final sample consisted of 586 respondents. Overall, 68% of respondents said they definitely or probably would choose to get vaccinated if a safe and effective FDA-approved RSV vaccine was available. That proportion increased to 77% if it were recommended by a healthcare provider. Among those expressing hesitancy to accept the vaccine, the most common reasons included lack of knowledge about RSV and both long and short-term safety concerns about the vaccine. The workgroup consensus was that older adults do, or probably do, feel that the desirable effects of RSV vaccination are large relative to the undesirable effects. However, the workgroup also believed that there was, or probably was, important uncertainty or variability in how much older adults value these main desirable and undesirable outcomes of vaccination. Next, I'll present data informing whether an RSV vaccine recommendation would be acceptable to stakeholders. Here, I'll describe results from a survey of physicians conducted in 2017. Surveys were administered to a national network of physicians who agreed to participate in surveys about vaccine policy and who spent at least half of their time practicing primary care. 2/3 completed the survey. Among those respondents, 317 reported taking care of an adult patient who they thought had RSV in the last 12 months, and they were included in the final analysis. A majority of physicians believed that RSV was a very important pathogen in adults of any age with an immune-compromising condition, and in adults 65 years and older with cardiopulmonary disease. By comparison, approximately 1/3 of physicians believed that RSV was a very important pathogen in adults 50 to 64 with cardiopulmonary disease and in adults 65 years and older without cardiopulmonary disease. The workgroup felt that generally, recommending RSV vaccines for adults 65 years and older would or probably would be acceptable to stakeholders. However, some workgroup members noted that a limitation of these published results was that only physicians were surveyed. Other clinicians, including pharmacists who order or administer vaccines, may have responded differently. Next, we'll discuss feasibility. Feasibility barriers might arise from vaccine storage and handling requirements, increasing complexity of the adult immunization schedule, and from financial barriers. Here are the storage and handling requirements for the 2 products under consideration. Both vaccines require reconstitution of powder and liquid components, both of which will come supplied in the purchased kit. Both vaccines require refrigeration at 2 to 8 degrees Celsius with protection from light. And after reconstitution, both vaccines should be administered within 4 hours, otherwise discarded. Now, here is CDC's older adult routine immunization schedule. With the potential addition of a regularly scheduled COVID-19 vaccine, as was discussed at VRPAC last month, the immunization schedule is becoming more complex. And vaccination is not the only age and risk-based preventive healthcare that adult clinicians must provide. If an RSV vaccine is added, clinicians will likely face competing priorities at each patient appointment. Different age cutoffs may also add to the complexity. Harmonizing age recommendations with those of other older adult vaccines may improve feasibility and may increase uptake. At age 65, all adults are recommended to receive pneumococcal vaccination. And there are specific influenza vaccine formulations licensed for adults 65 and older. Finally, recipient feasibility barriers include time and financial considerations. Older adults without health insurance coverage may experience financial hardship obtaining an RSV vaccine. Financial hardship may also arise if vaccine recipients need to take time off from work to be vaccinated or due to post-vaccination reactogenicity events. The work group felt that overall, both the GSK and Pfizer candidate RSV vaccines are feasible to implement among adults 65 years and older. For the resource use domain, I will not repeat the content presented by Drs. Hutton and Ortega-Sanchez. Rather, I'll present the work group's interpretation of the cost-effectiveness analyses. The work group felt that RSV vaccination for older adults could be a cost-effective intervention, but that the cost-effectiveness depends on several factors around which there's substantial uncertainty. Work group members felt that the uncertainty is chiefly driven by uncertainty in the annual incidence of severe RSV illness, particularly hospitalization, in the ultimate vaccine acquisition cost, and in the duration of protection resulting from RSV vaccination in this population. The work group was concerned about the net societal costs resulting from scenarios in which the vaccine acquisition costs were those assumed by the manufacturers. On the other hand, although the net societal costs in some modeling results were high, the work group noted that none of the 3 models incorporated medical costs resulting from longer-term sequelae of RSV infection. For instance, inclusion of costs of admission to skilled nursing facilities among adults discharged from RSV hospitalizations might lower the net societal costs estimated in the analyses. Finally, the work group noted that vaccination of older age groups would be more cost-effective than vaccination of younger age groups. All evidence taken into account, the work group responded that yes, or probably yes, both candidate vaccines could be reasonable and efficient allocations of societal resources if recommended for adults 65 years and older compared with no RSV vaccine. Finally, we'll discuss equity. We know that RSV disease does not impact all US adults equally. Here are incidence rates of RSV hospitalization published last year from 3 US states, showing that at every age group beginning at 45 years, incidence was highest among adults living in low-income zip codes and lowest among those living in high-income zip codes. In addition to differences by income level, RSV has differing impact by race and ethnicity. This table shows median age of adults hospitalized with RSV recorded in CDC's RSVnet, stratified by race and ethnicity over the seasons spanning 2015 to 2020. You can see that Black, Hispanic, American Indian, and Alaska Native adults hospitalized with RSV were younger than adults overall. In fact, at least 50% of adults in these age groups would not have qualified for RSV vaccination if there had been a recommendation for adults 65 and older. As we discussed in the public health problem domain, certain chronic medical conditions increase the risk of severe RSV illness. Adults who are Black, American Indian or Alaska Native, and Hispanic have higher prevalence of many of these conditions, including cardiovascular disease, diabetes, and asthma, when comparing with non-Hispanic white adults. The same is true of adults with lower income or socioeconomic status. In these demographic groups, these conditions are also diagnosed at earlier ages, often before age 60, increasing the risk of severe RSV disease earlier in life. Like most medical interventions, access to a new RSV vaccine may be determined by health insurance coverage, and we know that lack of health insurance is more common among adults younger than 65. However, even this disparity is not evenly distributed in the US population. American Indian, Alaska Native, and Hispanic persons aged 55 to 64 are substantially more likely to be uninsured than their age peers in other racial and ethnic groups. Depending on the age at which an RSV vaccine is recommended, this may exacerbate existing health inequities among older adults. And similar to the relationship between race, ethnicity, and health insurance coverage also differs by household income. Especially below age 65, the proportion of adults without health insurance is much higher among those with a household income that's below 3 times the poverty threshold than it is among those above that threshold. Again, depending on the age at which an RSV vaccine recommendation is made, this may exacerbate health inequities among adults. Overall, the work group felt that a recommendation for RSV vaccination among adults 65 years and older would, or probably would, increase health equity. Here's a summary of the work group judgments in each domain. I will not rehash that for the sake of time. So in summary, both candidate vaccines demonstrated significant efficacy against lower respiratory tract illness caused by RSV among older adults. However, the trials were underpowered to show efficacy against RSV hospitalization, and demographic groups at highest risk of severe illness with RSV, including adults 80 years and older, were underrepresented in the trials. At least one case of inflammatory neuropathy has been observed among recipients of each investigational vaccine. So the work group feels that if either vaccine is licensed, post-licensure surveillance for both safety and effectiveness will be critical. The work group notes pros and cons to the choice of age cutoff for an age-based recommendation. If a recommendation is made for adults 65 and older, the target population would be at greater risk of severe RSV disease, and therefore the balance of risks and benefits of vaccination would be more favorable. The work group was concerned about the possible risk of inflammatory neuropathy, particularly in light of the low observed RSV hospitalization rates in the trials impacting that balance. It would also align with the age-based cutoff for certain influenza vaccines and pneumococcal vaccination. On the other hand, this selection would exclude adults 60 to 64, among whom certain racial and ethnic groups are impacted by RSV at earlier ages. If a recommendation is made for adults 60 and older, there's the potential to prevent a greater total burden of RSV disease, and it would increase access to persons 60 to 64 with medical risk factors for severe RSV illness. On the other hand, persons 60 to 64 who are uninsured would have more difficulty obtaining vaccination, counteracting some of these potential gains in equity. As we've seen, clinicians may also be less willing to adopt a recommendation among adults younger than 65. And we've shown that such a recommendation would be a less efficient allocation of our collective societal resources. I'll now present the work group's summary interpretation regarding GSK's candidate vaccine. For an age threshold of 65 and one of 60 years, the work group felt that the desirable consequences of a vaccine recommendation probably outweighed the undesirable consequences in most settings. However, when considering a recommendation at age 60, there were substantial minority opinions that the desirable and undesirable consequences were closely balanced, or that there was insufficient evidence to make a determination. The majority opinion was in favor of recommending the GSK candidate vaccine for adults 65 years and older, but was not in favor of a broader recommendation for adults 60 years and older. Saying that, there was a substantial minority opinion not to recommend this product based on currently available evidence. These workgroup members were concerned about the balance of risks and benefits, considering the single case of inflammatory neuropathy observed in a recipient of the investigational vaccine and the underrepresentation in the clinical trials of adults older than 80 who are at greatest risk of severe RSV illness. They felt that it's imperative to demonstrate efficacy in this age group prior to making a recommendation. Further, they felt that a post-implementation safety signal for inflammatory neuropathy, even if caught early, could undermine confidence in RSV vaccines and in vaccines more generally. Among workgroup members who did support a recommendation among adults 65 and older, there was also a minority opinion to include a recommendation for individual adults aged 60 to 64 years based on shared clinical decision-making, intended to facilitate access to the vaccine among adults with medical conditions placing them at high risk of severe RSV disease. Now, moving on to the Pfizer candidate vaccine. For an age threshold of 65 and one of 60 years, again, the workgroup felt that the desirable consequences of a vaccine recommendation probably outweighed the undesirable consequences in most settings. However, when considering a recommendation at age 60, there were substantial minority opinions that the desirable and undesirable consequences were closely balanced or that there was insufficient evidence to make a determination. The majority opinion was in favor of recommending the Pfizer candidate vaccine for adults 65 years and older, but was not in favor of a broader recommendation for adults 60 years and older. However, as with the other candidate vaccine, there was a substantial minority opinion among workgroup members not to recommend this vaccine based on currently available evidence. Similar to the considerations for the other candidate vaccine, these workgroup members were concerned about the balance of risks and benefits considering the 2 observed cases of inflammatory neuropathy and the underrepresentation of the very oldest adults in the clinical trials. Among workgroup members who did support a recommendation among adults 65 and older, there again was a minority opinion to include a recommendation for individual adults 60 to 64 years based on shared clinical decision-making intended to facilitate access to the vaccine among adults with medical conditions that place them at high risk of severe RSV disease. With that, I want to thank my colleagues who helped develop this presentation. And our policy questions for ACIP are whether each of these 2 candidate vaccines should be recommended in US adults age 65 and older, or whether they should be recommended in US adults age 60 and older. Thank you. That concludes my presentation.
Thank you, Dr. Melgar. Before we take questions, there are 2 requests for comments, one from GSK and one from Pfizer. I'm going to ask both representatives if they would be please willing to limit their comments to 3 minutes or less. First, we have GSK, Dr. Len Friedland on the line. Dr. Friedland?
Yes, hello, can you hear me?
We can, thank you. Please go ahead.
Thank you, members of the ACIP, for giving GSK the opportunity to make a brief statement. I'm Dr. Leonard Friedland, Scientific Affairs and Public Health at GSK. On behalf of my GSK colleagues, we are proud to have developed the GSK RSV candidate vaccine for older adults being discussed at ACIP. I will focus my remarks to the policy consideration of should 60 to 64-year-olds be included in routine RSV vaccine recommendations. RSV results in considerable clinical and economic burden in all adults age 60 and older, including those age 60 to 64. GSK's cost-effectiveness model, which uses burden of disease estimates that align to the current body of published scientific evidence, estimates that vaccinating 60 to 64-year-olds would result in roughly 260,000 fewer symptomatic RSV cases in 60 to 64-year-olds, including over 100,000 fewer outpatient visits and around 7,400 fewer hospitalizations each year. The model found that GSK's RSV vaccine is cost-effective across a range of price points, indicating that the vaccine would be considered a good public health value for adults 60 years of age and older. In addition to reducing the burden of RSV, including 60 to 64-year-olds in RSV vaccine recommendations would also importantly have health equity benefits. Studies have demonstrated that certain racial and ethnic minority groups are more likely to have underlying risk factors for severe RSV outcomes, are more likely to be diagnosed with risk factors for severe RSV at younger ages, and are more likely to have undiagnosed risk factors, particularly in younger ages before they are eligible for Medicare. Studies have also found that certain racial and ethnic minorities are more likely to have severe RSV-related outcomes, including a study being presented by the CDC at the RSVNet conference this week that demonstrates that a higher proportion of younger adults hospitalized for RSV were Black, Hispanic, or American Indian Alaska Native. Excluding 60 to 64-year-olds from age-based routine recommendations would be detrimental to the racial and ethnic groups who develop risk factors for severe RSV at younger ages. Additionally, Shared clinical decision-making recommendations at any age would be detrimental to the racial and ethnic groups who have undiagnosed risk factors. Age-based RSV vaccine recommendations for adults 60 years and older would ensure equitable access across all older adults. To spend a moment on GSK's candidate vaccine, the vaccine is highly efficacious in adults with one or more underlying comorbidities of interest. Data on co-administration with high-dose influenza and adjuvanted influenza vaccines and vaccine efficacy through 2 RSV seasons will become available in the second to third quarter this year. We appreciate all the work that CDC and ACIP are doing to improve the lives of older adults and to improve health equity. We look forward to continuing collaborative discussions. Thank you.
Thank you for your comment. Next, we'll move on to Pfizer, Dr. Alejandro Cane.
Yes, thank you, Dr. Lee. Can you hear me?
We can. Please go ahead.
Okay, thank you again, and thank you to the ACIP member for the opportunity to provide Pfizer comments. I think Pfizer is very proud to share that our vaccine, our PF vaccine, represents our commitment to developing a target preventive measure to address an important unmet need for RSV illness, which has been largely unrecognized and underdiagnosed in adults. We recognize that there are many unanswered questions, such as duration of protection, need for future revaccination, and the magnitude of underdiagnosis of RSV illness in older adults. As such, economic modeling is necessary based on uncertain inputs and assumptions. While vaccine price plays a role in the evaluation, as I has mentioned before, it's also important to know that the BOD, the burden of disease, is a critical aspect to be considered. In fact, the University of Michigan CDC model that was presented earlier today, used in older adults, assumes a hospitalization incidence rate of 108 per 100,000 persons per year among adults 65 plus adults. This is arguably the main input difference in the vastly disparate cost-effectiveness results for the CDC model versus either the Pfizer or GSK models, which use base case incidence of 300 and 256 cases per 100 adults per year, respectively. That is fully aligned with a recent CDC published data at RSV in Lisbon that reports on hospitalizations incidence rates among adults 65 and older of 240 to 356 cases per 100 persons per year. Pfizer remains committed to developing vaccines as a public health strategy, as has a goal of achieving the broadest possible availability to vaccines by eliminating barriers to vaccine access and uptake. We look forward to working in the upcoming months with the CDC to continue to collect data and inform this important question to further support policy discussions on RSV vaccine use in adult population. Thank you very much.
Thank you for your comment. Now we will open it back up to questions and comments for Dr. Melgar and the work group. Dr. Paling.
I want to say thank you to the entire work group because this is complicated and exciting. RSV is an important cause of illness in both extremes of aging, and the potential here is really exciting. And I want to make sure I'm understanding this correctly because safety is an important component of our decisions. And so, Dr. Melgar, I'm trying to make sure I'm understanding what you have presented correctly. The inflammatory neuropathy or Guillain-Barré syndrome was observed in 1 out of 15,000 in the GSK open trial, in 2 of the RSV recipients out of 26,000 in the Pfizer clinical trial. And if that is correct and consistent, then there's the possibility that this could be a side effect in 1 in 13,000 to 1 in 15,000. Though there's uncertainty because our numbers are small. Am I interpreting this data correctly? Thank you.
Thanks, Dr. Paling. Yes, you are interpreting the total numbers correctly. I think the distinction may be somewhat subtle in terms of in which trials these cases occurred. In GSK's case, It occurred in an open label trial. There was one case, it occurred in an open label trial. In fact, give me 1 second. All right, so in GSK's case, the single case of Guillain-Barré syndrome was observed in an open label trial, phase 3. It was randomized, but none of the arms included a placebo arm, and that's why it was not included in GRADE. The intent of this trial was to evaluate different revaccination schedules, and that's where the randomization took place. There were a total of 1,650 adults aged 60 years and older that were enrolled. Among them, around 4% reported at least one serious adverse event. And one of those serious adverse events was a case of Guillain-Barré syndrome that occurred 9 days after vaccination. It was reported as related to the investigational vaccine by the investigator. It was in a 78-year-old female in Japan. The level of certainty of the diagnosis of Guillain-Barré syndrome was Brighton collaboration level 3. It led to hospitalization lasting 179 days, and the patient recovered. So this was the one and only case of inflammatory neuropathy that occurred in GSK's safety database that spans all of their clinical trials, in which there were a total of 15,000 approximately RSV vaccine recipients. In Pfizer's counts, so Pfizer's 2 cases of Guillain-Barré syndrome or a variant thereof, one of them was diagnosed as Miller-Fisher syndrome. Both of them occurred in Pfizer's pivotal phase 3 trial, in which there was indeed a placebo arm. And you can see the numerators and denominators here. But again, when you sum across all of Pfizer's clinical trials, there were approximately 26,000 RSV pre-F vaccine recipients and a total of 2 cases of inflammatory neuropathy. So if you were to, so your summary of 1 in 13 to 15,000 is correct for both investigational vaccines. Though again, I would point out that 1 to 2 cases is very sparse to actually calculate a rate, which is why we did not attempt to do that.
Dr. Sineas?
Thank you. In follow-up to Dr. Palin's questions, do we know any more characteristics of the 2 patients in the Pfizer trial, and any more details on the 1 patient from the GSK, other than the age of 78?
I shared all of the details that I know about the GSK single case, and yes, we do know a little bit more about the 2 cases from the Pfizer phase 3 clinical trial. Both occurred among patients in their 60s. One was in the United States and male. One was in Japan and female. The patient in the US initially suffered a non-STEMI after 7 days after vaccination with the investigational vaccine. The day after developed new onset weakness. There was a nerve conduction study that diagnosed acute demyelinating polyneuritis of the lower extremities, and this was diagnosed with certainty Brighton collaboration level 1 as Guillain-Barré syndrome. The other one was the Miller-Fisher syndrome variant diagnosed retrospectively. The onset was 11 days after vaccination with the RSV pre-F vaccine, and the certainty was Brighton collaboration level 4. And this is the level of detail that, that was provided by the manufacturers.
Dr. Talbot?
Yeah, I'm super excited about having an RSV vaccine and looking forward to preventing hospitalizations in older adults and improving quality of life. Do you want to say I would like some more data, and I would like to kind of list the concerns and thoughts and needs that I would have. One is, I am pretty sure if we prevent disease, we prevent hospitalizations. But in these trials, we saw hospitalizations for Guillain-Barré, but did not see the prevention of hospitalizations for RSV. And so we have to balance that risk-benefit in the long run. 2, this vaccine will be given with COVID and flu, and we need co-administration data. We need co-administration data for all of these. Along those lines, we're moving COVID to Part B Medicare, and that would leave RSV as Part D. So the likelihood of them getting flu and COVID in their physician's office, and then later, maybe days later, going to get the RSV vaccine or may not is up in the air. There is no data on VE in nursing home patients, and they have the highest morbidity and mortality from this disease, and we have no knowledge if it would even work in this population, nor do we know the side effects that would occur in this population. Next, we don't know the VE in those over 75 years of age, where the highest morbidity and mortality is behind those that are in the nursing homes. I think I'll stop there. I have some other concerns, but I really want this vaccine to come to market, but I want it to come with good, solid safety data and good, solid vaccine efficacy data so that when we introduce it, we have confidence in recommending it in our older adults and that our older adults have confidence in the vaccine.
Dr. Goldman, I see your hands raised.
Thank you, Dr. Lee. First, to the work group, thank you for this presentation. It's a lot of information. Wanted to make kind of a comment for the committee to consider. As an internal medicine physician who routinely sees patients with RSV and gives all the adult vaccines, one of the things I'm struck by is before the PCR testing commercially available, I didn't know if it was a viral infection from what cause until I was able to test them. So I'm seeing a lot more RSV diagnoses for what I thought were just routine viral syndrome. So I think part of the piece is going to be educating the physician population, the physician workforce to understand the prevalence and relevance of RSV. So I think that will help a lot in getting physicians to implement and use a vaccine if it is approved. I am really concerned about risk-based strategies as opposed to pure age-based. I think the age-based is a more appropriate way to go, whether it's 60 or 65, because when you start doing the risk-based, when I try to talk to my patients about it, their concern is, well, I'm not at risk, so therefore somehow I'm immune to the virus, even though we know that's not true, but they don't see it that way. So if we're doing shared clinical decision-making or a risk-based approach, we're going to lose that opportunity to vaccinate at-risk patients who don't realize it. So plus, it makes it way more complicated for physicians to implement in the office. And then two quick more comments on the finances of things. The Part D concern, it is possible for physicians to be able to implement Part D vaccines and be reimbursed for it, but it is difficult. So that's a consideration as far as what schedule it is with CMS and how they approach those things. It is possible, but it's difficult. And I too also think that this really does speak for the need for a VFA, a vaccine for adult program, so that we can address some of these concerns. But I really appreciate this work. I'm excited about the possibility of this vaccine, as Dr. Talbot is, but really hope that we take into consideration how we implement it on the ground floor level in the clinic and how important it is to communicate the importance of it to physicians. Over.
Thank you. Dr. Lear?
Wanted to follow up on that last comment, 2 points. While I totally agree that it's difficult to get Part D vaccines paid for in the office, I do want to thank CMS because it has been much easier in 2023 than it was in the past. So I do appreciate the change and look forward to more changes. I also had a question. When Dr. Hutton did his analysis, the CDC analysis, you used a 95% PCR test sensitivity, and then GSK and Pfizer used studies from Zhang and McLaughlin to either use a 1.4 or 1.5 estimate of higher incidence of RSV. And I'm just wondering if someone could sort of give me their perspective on how accurate that 1.5 or 1.4 estimate would be. I noticed you didn't choose to use it, but I'm just sort of curious because that would clearly change the cost-benefit analysis if there's more RSV out there. Thank you.
Yeah, I can answer those questions. Again, this is Michael Melgar, CDC Work Group Lead. So the multipliers of whether it's 1.4, 1.5, or 1.6 fold over and above detection by upper respiratory PCR are based on a collection of a growing body of literature that suggests that if you were to universally test every patient that came in with a compatible illness with acute and convalescent serology and or other specimens for PCR like sputum, then you would detect additional cases of RSV that were not detected by an upper respiratory PCR. And there is still a tremendous amount of uncertainty of how much additional RSV there actually is because of that under detection. So I guess I'll say first that in the CDC model, we opted for the most conservative approach in the sense that we did not implement any such multiplier, and we simply compared the sensitivity of multiplex PCR, in other words, looking for multiple pathogens at once on an upper respiratory specimen, compared with this as a gold standard, the RSV PCR singleplex. And the best estimate that exists is that the sensitivity there is 95%. We fully acknowledge that the CDC model assumes pretty much in all inputs the more conservative assumption possible. So to what extent there is under detection and how great that is an area of active investigation. And I think that the confidence intervals sort of reflect that. And unfortunately, I recognize that ACIP is faced with a decision with a tremendous amount of uncertainty about how much RSV disease actually exists because of that fact.
If I could follow up then, when the studies were done, they were probably using the PCR multiplex or something like that. So that's the comparison that was there. The extra data wasn't available to the studies to say that they've got more RSV when Pfizer and GSK did their studies. Would that be fair? So they did their studies based on the RSV that they found, and they found efficacy. We might be finding more RSV, but we actually don't know from the studies whether that extra RSV is clinically significant.
I see. Yeah. So the case definitions I think you're referring to in the GSK and Pfizer clinical trials involved upper respiratory PCR specimens. So in theory, I think what you're getting at is these additional cases, if you were to multiply by 1.4, 1.5, or 1.6, are those clinically relevant additional cases that are significant disease? Many of those studies were conducted in hospitalized patients. So I think the answer is probably yes, with quite a bit of uncertainty. And there is some evidence as well that BALs also detect additional cases that are not detected by upper respiratory PCR. So those are usually done in quite severely ill patients. And I guess the last point I'll say is that even the CDC model, one of the scenarios that we included was multiplying by 1.4 the baseline or the base case assumption of RSV hospitalization incidence to try to account for that. And indeed, the cost effectiveness was much better when we implemented that assumption. Thank you.
Dr. Talbot?
Yeah, so I was just going to say, the studies that were up there were done a couple different ways. RSVNet, the most well-known one, is we actually mine the charts of people who were diagnosed clinically for RSV. And so those studies are limited by the fact that not all clinicians test for RSV. And that team has put a lot of time and effort into figuring out what percentage is actually tested and then to extrapolate to the full number. Some of those studies up there, like the Widmer study, approached everyone who came to the hospital with a respiratory illness and tested them regardless of what the clinician was doing in a lab. So all of them were tested prospectively for RSV regardless of what was going on clinically. So that gives you some of the idea of the spread of why there's so much variability in those numbers.
Thank you. We're going to take 3 more questions. One of them's from me. Actually, it's more of a comment. I don't think you'll be able to answer today, but I'm having a hard time answering your policy questions, in part because I do feel like there's additional information that would be helpful. And actually, even though we saw the cost effectiveness models today, there are 2 aspects that I actually would love to see with updates in the modeling. One is a better understanding of the longer term outcomes that go beyond RSV infection, as an example, just because we know that a lot of older adults who develop a respiratory viral illness can get admitted for other reasons, like myocardial infarction or strokes or other things that are maybe triggered by the infection, but result in some other comorbid conditions that actually have substantial impact on people's lives. I believe there's data out there that might relate to Dr. Talbot's, nursing home, point, which is how much data do we have, and can we think beyond the infection itself to other consequences of the infection? So that's what I mean by, quote, long-term outcomes or other outcomes that might be of interest. The second would be an explicit incorporation. So I recognize there's uncertainty and there's a very low numbers, but given 1 in 15,000 and 2 in 30 or 35,000, given that uncertainty, it seems to me incorporating that explicitly into modeling to understand what the potential impact might be helpful. We've done this before, and in part of that recognition is that, for example, respiratory viral illnesses also result in inflammatory neuropathy. So you may be preventing more than, and we don't know for sure what the rate is, but I just think that balance is going to be really helpful, at least to me, to be able to understand how to think through the benefit-risk balance, and then I can understand whether or not the 60-year-olds or the 65-year-olds make sense. I will say that there is that equity issue is a really important one, but the other issue I'm very confused about is if the time horizon, let's just say it lasts for 2 years, then we've protected them for 1 or 2 years. But then what about the year after that? And so it's so not only is it, in order to maintain that benefit, you would have to think about repeated vaccination, you would have to think about the cumulative costs, and you would have to think about the cumulative risks. So that's the part where I'm not understanding beyond 1 season where to get to. So that would be really helpful for me.
Thanks. I can begin to respond to a few of these comments. One noted, so other outcomes other than hospitalization for respiratory illness. I'll go back and discuss with our epidemiology subject matter experts to see if we can incorporate hospitalizations for other causes, perhaps costs associated with post-discharge, into the cost effectiveness models. I will say up front that, similar to what I had said before, a lot of these things are better characterized for influenza than they are for RSV. But we'll investigate what we can do to incorporate that, at least in the cost effectiveness modeling. So regarding Guillain-Barré syndrome and, inflammatory neuropathies in general, so yes, many patients who present with an illness compatible with Guillain-Barré syndrome report having had an upper respiratory illness, in the weeks preceding. We did a literature search regarding any association with RSV in particular. There's very little, and in the published literature linking those two. And in part, that's, I think, because very few adults are tested for RSV. So there isn't, I can't offer you a rate of Guillain-Barré syndrome or other inflammatory neuropathies that results from infection with RSV. I can say that there are case reports in patients that have had RSV and then present, but there's nothing I can offer in terms of a causative link or a rate. And then finally, regarding the time horizon of protection and the question of revaccination, so we the work group feels that there's insufficient evidence right now to recommend a revaccination interval or revaccination at all, which is why the policy questions are phrased from a perspective of a one-time dose. That being said, both GSK and Pfizer are conducting multi-year phase 3 clinical trials. And what I presented today is limited to the first RSV season following a single vaccination. And in the coming months, the timeline would be very difficult for both manufacturers to present anything before June, but in the coming months, there will be a second RSV season's worth of follow-up in both clinical trials. So we will have some evidence regarding whether the duration of protection extends beyond a single RSV season. But in the face of uncertainty for that reason, the policy questions were phrased as a one-time dose.
Thank you. And and I forgot the whole reason I was thinking it would be helpful to see an update of the cost effectiveness models is because I'd actually like to see the cost of the vaccine, because that actually also might influence the way I think about the decision. Okay, sorry. Actually, Dr. Brooks is next.
Yeah, thank you. So just in addressing the 60 to 64-year-olds, first of all, Dr. Goldman noted that he's much more in tune with those having RSV. The survey done of physicians was done in 2017, so that was likely before that was available to him and others. So there is more RSV out there, as we're seeing. The quality, one of the slides showed the quality kind of balancing out or having a mark at 60 years of age for $50,000, which is kind of an unofficial benchmark for quality, age 60. And then the mention of the long-term outcomes that you had asked about, Grace, that had been brought up earlier, that's going to be even higher in the African-American population, those with lower socioeconomic status. So, and I wasn't impressed with the cons on the shared decision-making slide as related to equity. So equity to me was really not addressed, right? Because it was, but not to my satisfaction. So I would be in favor of the 60 to 64 added as a shared decision making. I don't think I would go to 60 as the age of vaccination, but I'm not really seeing a heavy downside to adding that as an asterisk, if you will, for for the first two bullets.
Thank you, Dr. Brooks. Dr. Long, Ms. Hayes, and then we're going to take a break.
The question about the inflammatory neuropathy, in the work group, it was impressive to people who had lots of experience and expertise in adult vaccine programs, that it was odd, that it was noteworthy that these cases appeared, because they had not appeared in very large vaccine programs, as in coronavirus vaccine programs. So that was one thing that gave us pause. And the second was the group that you most want to prevent. We really had no useful data, and we felt that was not our fault, that we couldn't make a recommendation. We don't have the data. And the other thing that maybe Dr. Melgar or Dr. Cotton, you'll remember, when we were considering the ages of immunization, to immunize everyone over 60, if there was inflammatory neuropathy at 1 in 15,000, that would be 5,000 cases of inflammatory neuropathy. And that would, cause all kinds of mistrust. So we thought we should be very conservative, and then when we went to look at the group that was most likely to benefit, we didn't have the data to be sure that they would benefit adequately. But what I'm trying to remember is, isn't the incidence, natural baseline incidence of inflammatory neuropathy goes up with age? Is that correct? So this group that we want to protect the most might, and we don't know if it works, might be even at significant risk. And that would that gave me pause also for shared decision-making for younger people to take the risk of a potential problem, adverse event, when we really don't know what that, we can't inform people well on what that risk is.
I can say a few brief words. Yeah, so while we can't quantify the risk of an inflammatory neuropathy following RSV infection, you're correct, Dr. Long, that the incidence independent of any specific exposure in the general population has been shown to increase with increasing age, as is summarized on this particular backup slide from 2 independent publications within the last 10 years. But as you can see, the actual number or the rate per 100,000 population per year, even across these 2 studies, is quite different. And I think speaks to the uncertainty in the baseline risk of inflammatory neuropathy as well.
And we have seen with other vaccines that the background risk, age-related background risk, goes along a little bit with vaccine-associated risk. If there is a vaccine-associated risk, I'm thinking of myopericarditis following vaccination in young males, for instance. That is the age at which myopericarditis is most likely to happen in natural background. So it may be a harbinger.
Ms. Hayes, do you have a quick comment? And then we'll...
I just had a quick clarification on slide number 152, and when you did the age, the lack of knowledge and the concerns, you may not have this data right off the top of your head, but I was just curious what the age range was of the individuals who were surveyed.
Thanks for the question. Are you referring to the general population values survey?
People's opinions about whether or not they would get vaccinated, and the title of the slide was lack of knowledge, and it was you're listed as 152 on your slide.
Mm-hmm.
So I was just curious, were these older people, younger people, middle-aged people, like people over 65?
Yeah, I have the demographics of the survey participants on the slide here, slide 149. So in order to be eligible to complete the survey, adults had to be 60 years or older.
Great, thank you. I missed this slide earlier. I appreciate that very much. So you had to be 60 or over. Perfect, thank you.
Thank you. And Dr. Cotton, last word.
I just wanted to say that in thinking this over, and there's so much information, and some of it's conflicting, and we wish we had more information about RSV. We wish we had more information about RSV and the potential Guillain-Barré syndrome from RSV, et cetera, et cetera. We actually, the reason we came down to sort of preferring the age 65 cutoff was we thought we might start with that and then expand, but based on risk and benefit and multiple different factors. That's why we sort of came to that conclusion in the work group. Again, this was very challenging. I really appreciate all the work that Dr. Melgar and everyone from the CDC and others did, as well as everyone in the work group. It was a great amount of work, and we're truly appreciative. Thank you.
Thank you. And with that, we're going to take a break until 40 minutes after the hour. We are running 15 minutes behind schedule, but it's not too bad given how intense the conversations are. So thank you, everybody.